Thanks, Di, and welcome again, everybody, to today's webinar organized by the Mental Health Economics Special Interest Group. My name, as Di said, is Francesca Cornaglia, and I'm a reader in economics at Queen Mary University of London. And I will be chairing with Julia the event today. Just a couple of words about the SIG. The Mental Health Economics SIG is a community of currently around 200 IHEA members who share a common interest in the economics of mental health. And the aim of the group is to build and strengthen connections between researchers that are interested in this topic, so that also opportunities of learning are generated. As we know, mental health community continues to be a topic which is somehow neglected in many contexts, despite its importance to not only patients, but families, communities, and the economy as a whole. And it does throw up lots of interesting research challenges to all of us. What we hope to do with the webinars is to provide an important platform for exchanging ideas and disseminating research on the economics of mental health. And we are very happy that you're here today with us, and we hope you'll enjoy the event. So we have today the pleasure of having with us Rowena Jacobs, who will be talking about serious mental illness. Rowena is Professor of Health Economics and Deputy Director of the Center for Health Economics at the University of York. She has expertise in economics of mental health and mental health policy, and she's done work on the evaluation of mental health policy incentives and reforms, as well as on funding, contracting, and performance measurement of mental health services. Personally, I find particularly interesting her research on physical and mental illness multimorbidity. She leads several multidisciplinary research programs. She has raised funding from Department of Health, the NIHR, the MRC, and the ASRC, among others. And her research has also won several awards, including in 2019, the William Willard Manning Award in Mental Health Policy and Economics Research. She's also, with her work, had significant impact on society. For example, she's acted as an advisor to the UK government, to the World Bank, the WHO, and the OECD. So we're really very pleased to have Rowena with us today. Rowena, the floor is yours. I kept my talk very short so that you could have at least 40-45 minutes to talk. If anyone has questions while Rowena is presenting, could we please ask you to either type the questions in the chat or jot it down, and we'll promise that we'll do our best to go through them in the Q&A at the end. That should be around 15 minutes. So Rowena, the floor is yours, and thanks again.
Thank you so much, Francesca. It's really lovely to be here. This is a topic which is really close to my heart. So I'm really delighted to be here with fellow people interested in the economics of mental health. So when we focus on serious mental illness or severe and enduring mental illness, there are a couple of things which I wanted to focus on today. So I will talk for around, I'll aim to be around maximum 40 minutes, and then there'll hopefully be some time for discussion at the end. So I suppose I wanted to shine an economics lens on why we should be focusing on people with serious mental illness. How do we define SMI? What is the prevalence of serious mental illness? What are the costs? And there are a whole range of different costs. What are some of the challenges for policymakers, and how do we care for people with serious mental illness? And how does the nature in which we care for people affect their outcomes? So again, you know, what can policymakers do to improve outcomes for people with SMI? So that's the outline of the talk today. Let's start by why, as economists, we should really care about this particular population group. So I think probably first and foremost is that people with SMI experience some of the worst inequalities, and probably the greatest health inequality of all, which is that their life expectancy is between 10 and 20 years sooner than the general population. They die. And this is essentially the life expectancy which people experienced in the 1950s. And there's some evidence that this mortality gap is actually widening. So SMI is very rarely the cause of death. It's often even not recorded on death certificates. So people with SMA die prematurely. And the main reason this happens is actually because of physical health conditions. So SMI might be a significant feature of why they've died prematurely, but often it's because of the chronic physical health conditions. But SMI clearly influences their lifestyle, their risks factors, their access to health services, and how they manage those physical health conditions. But around 2/3 of these premature deaths are indeed preventable. I think that's probably one of the greatest inequalities of all. So just to show you this increasing gap, so this is a picture of excess premature mortality. So what do we mean by this? Is this is essentially the comparison between people with SMI and those without SMI, and the comparison of them dying before the age of 75. And this is a figure which looks at 3-year age bands, 3-year period bands from 2015 to 2017 through to 2018 to 2020. And we can see that this excess premature mortality is increasing. So if you were to have a figure of 0%, it would essentially mean that there's no difference, that people with SMI are not dying sooner than people without SMI. But we see that this percentage is around between 350 and 400%. So people with SMI are essentially dying between 4.5 and 4.75 times sooner than, they're more likely to die prematurely before the age of 75 compared to people without SMI. And we can see that this gap is increasing over time. So the big driver of this mortality gap, as I said, is this morbidity gap. So people with SMI have a much higher probability of having multiple long-term conditions or experiencing what we call multimorbidity. So if we look at the population of people with SMI aged 15 to 74, we can see they're at least twice as likely to have conditions like obesity, diabetes, COPD, and so on. And more stark than this is if we look at the younger age group, so age 15 to 34, compared to the general population, they're at least 3 times more likely to have physical health conditions like obesity and diabetes and hypertension. So just to drive this point home in terms of the prevalence of multimorbidity for adults with SMI compared to all patients. So for example, the prevalence of having 2 or more physical health conditions in people with SMI is 1.8 times greater than other patients. And so, for example, for the prevalence of 4 or more or 5 physical health conditions in people with SMI is at least twice higher than for all patients. So they're much more likely to have these multiple long-term physical health conditions. So this is one of the big drivers of this morbidity gap, and some of the reasons for this increased burden of physical health is due to the social factors such as unemployment and poverty, stigma, discrimination, isolation, exclusion, which prevents people from seeking help. They're often a very disenfranchised, marginalized population experiencing stigma, and their healthcare isn't given the same priority as other chronic disease areas. They may also lack support to access care and services, and this means they're less likely to receive preventive care and health promotion interventions. They may also suffer from experience diagnostic overshadowing, which means that physicians are more likely to attribute their physical health symptoms to their mental health diagnosis. So for example, a patient comes in saying, I'm feeling very tired, and the physician is more likely to say, well, it's probably because of your SMI, rather than recognizing it as a genuine physical health problem, which could be, for example, metabolic disorder, and so that goes unnoticed, undiagnosed, and untreated. And then there's a whole range of health behaviors which can also impact, so smoking, substance misuse, and poor diet. And just to expand on that point a little bit more. So probably smoking is one of the single biggest risk factors still. So while smoking prevalence in the general population has dropped dramatically, it's still very, very high amongst people with severe mental illness, and they're much less likely to be given support to help stop smoking. The antipsychotic medications which they put on cause significant weight gain, and that can lead to all sorts of metabolic syndromes, which increases their risk of cardiovascular disease and premature death. And as a result of all these side effects from these medications, their compliance is generally much poorer. And this can lead to poorer outcomes for both their mental and physical health. There are some advances now in terms of trying to introduce self-management interventions, but there's also a whole range of lifestyle factors which can affect their physical health. So why? Well, if the mortality gap and the morbidity gap was not enough for us as economists to care about this particular population group, then I want to give you a couple more reasons why I think economists should care about studying this particular population group. So we've alluded to this already, the significant health inequality, and this is largely driven by a number of other socioeconomic inequalities. So people with SMI much more likely to be homeless. They're much more likely to live in the poorest household incomes, to be deprived and live in poverty. Much more likely to live alone and experience social isolation, to live in less safe neighborhoods. So these social determinants, the unequal distribution of these social determinants of health, education, housing, employment, these are a big driver of inequalities here. So people with SMI have these much higher rates of poverty, homelessness, incarceration, unemployment, and so on. So just to illustrate this, here is a picture of the premature mortality by deprivation quintile. And so on the left-hand side, we've got the most deprived quintiles, again, showing you over time. So this most deprived quintile, not only do they have the highest rate of premature mortality for people with SMI, but they also have the highest increase over time. So there's definitely a strong socioeconomic gradient here. We know that stable, good quality employment is a very protective factor for people with mental health generally, but also for people with serious mental illness. And there seems to be a bit of a stigma around getting individuals back into employment. Sometimes there's some negative attitudes and stigma around that. And so as a result, people are often overrepresented in low pay and in temporary work. But some studies are showing increasingly that among those who are unemployed with SMI, at least 2/3 of them express a really strong desire for work. So there's this sort of traditional view that employment isn't such an important factor in people with SMI's recovery, and that they're not interested or unable to work, and that seems to be a misperception. So they're very much less likely to get support to get back into employment. So the employment rates are really low. There was a very nice study by Grieve and Nielsen in Journal of Health Economics, which showed the relationship between schizophrenia and employment, and showing that individuals, even 6 years before actually having a diagnosis of schizophrenia, so those symptoms, that sort of prodromal symptoms were there already, their employment rate started dropping, and then it eventually stabilized at around 18%. So the employment rates are really, really low. A very nice recent study in the National Bureau of Economic Research working papers by Biasi showed the career effects of some of these severe conditions of mental health, and showed that they used individual level registry data from Denmark, showing the very large earnings penalties for people with some of these severe conditions, so ranging from 34% for people with depression, 38% for people with bipolar disorder, and 74% for people with schizophrenia. So we know as economists that this leads to reduced tax receipts, reduced earnings, reduced consumption expenditure, higher welfare payments, and lost productivity. The final reason why I think economists should care about this, obviously it impacts on the health services, but also crucially on individuals. We know there's reduced adherence to treatment, which we've spoken about. As a result, they have poorer health outcomes, increased costs, and of course, massive decrements to quality of life. So how do we actually define SMI? Well, it's not that straightforward. So in the US, in the early 1990s, the Center for Mental Health Services in the US, they had to define SMI because they had to hand out these mental health block grants proportional to the number of cases of SMI in each state. And so they defined SMI as any illnesses in the DSM, in their manual, that resulted in functional impairment that substantially interferes with or limits one's life activities. And so the conditions within the DSM that met this criteria tended to be primarily schizophrenia and bipolar disorder. But their definition, because it's a bit wider, because it's around functional impairment, seems to also have the ability to include major depressive disorder and some other conditions as well, if the functional impairment is severe enough. In the UK, we've been a little bit more narrow in the definition, which has tended to be used, and that's largely been based on the number of people in primary care who are on a practice register for people with serious mental illness. And so typically that includes people with schizophrenia, bipolar, and other psychoses, and more recently, patients on lithium therapy. So these different definitions no doubt give rise to different prevalence rates, and these definitions arise depending on whether it's for legal or clinical, epidemiological, or for funding purposes. So it's worth noting, for example, that in the Global Burden of Disease studies of 2019, there was various disability weights attached to these different conditions. So I suppose the point I'm trying to make here is that I don't think it matters too much what the condition is, whether the diagnosis is, whether it's depression or something else. I think the definition is really about the level of disability that it causes. We can see within depressive disorders, there can be a range of disability attached to the different levels of severity that might arise. But certainly schizophrenia and bipolar disorder tend to be the conditions which certainly meet the threshold. So what is the prevalence? Well, using this broader definition that we have in the US in 2020, we come up with a prevalence rate of around between 5.2% and 5.6%, depending on which statistics we look at, and that gives around 13 to 14 million adults who suffer from serious mental illness in the US. I think the point to note on this particular graph is that the prevalence is very high amongst young adults and those of working age. I think this is where the economics of mental health is often very different to the economics of physical health. It affects people of working age, and that has big knock-on effects for how, as economists, we might think about these conditions. In terms of the prevalence of SMI in the UK, the number of people on this primary care register is around 1% in 2020, but that only covers individuals in primary care. And it's very difficult actually for us to get very good prevalence rates in secondary care, and that's often because there's been quite poor diagnostic coding. So with this narrower definition in the UK, if we just focus on schizophrenia and bipolar disorder, and we just focus on the estimates that came out of the Global Burden of Disease studies, we think the prevalence is probably around 2.5%, something like that. So quite a bit lower than the 5.5% in the US. But again, this is due to the different definitions. So just having a look at the prevalence rates for schizophrenia and bipolar disorder, and more crucially, this is again from the Global Burden of Disease estimates, more crucially, if we look at the distribution here over the age categories, Again, I think the pertinent thing here for us as economists is that that is really prevalent amongst young adults and people of working age. So some other interesting bits and pieces of studies that have come out around prevalence of SMI, just focusing on the socioeconomic factors and the environmental factors. This first study, again, used these SMI registers in primary care to look at spatial prevalence. And they found that people living in more socially deprived areas and more socially fragmented areas were more likely to be diagnosed with SMI, but there was quite a lot of heterogeneity between regions. And the second study is one that we did, looking at, again, the people diagnosed with SMI on these primary care registers. And we associated those with environmental factors. And we found that people with SMI were more likely to live in areas where they are further away from green spaces with higher levels of air pollution and higher levels of noise pollution. But again, we also found similar levels of heterogeneity. So let's talk a little bit then about some of the costs of SMI. So there's a whole range of costs that as economists we may care about. So the economic costs more broadly for SMI are significant. So in the US, it's been estimated that economic impact is about 1.5% of GDP. And if you just look at the breakdown of these costs, around a third of that is healthcare expenditures, and a smaller proportion of that will be welfare payments, so disability benefits and so on. But the vast proportion of that, 2/3 of that, are these indirect costs, so the loss of earnings and so on. So it really has huge economic impacts, and it really outstrips the direct health and social care costs by a large margin. So if we look at these economic costs within the UK context, again, we've got this narrower definition, so probably this is an underestimate, but this study by colleagues from London School of Economics showed that the economic costs of mental health generally in the UK in 2019 were estimated at 116 billion, or 5% of GDP. And if we break that down for schizophrenia and bipolar disorder, that's probably around 1.5% of GDP. So this includes the indirect costs of lost employment. It includes informal costs, also the direct costs of health and care provision. But there's a lot missing in these estimates. It doesn't include absenteeism and presenteeism, doesn't include the costs of managing these physical health conditions for people with SMI. It doesn't include the decrements in quality of life and the impacts of self-harm or suicide. So probably this is a vast underestimate. If we just have a look at these direct healthcare costs, this is a study where we linked costs for people with SMI across the whole care pathway. So for primary care, for secondary care, and in specialist mental health care services. We did some two-part models here. So these are the non-zero costs. And I suppose the point I'm just trying to drive home here is that a big preponderance of these costs are the physical healthcare costs, the elective and unplanned admissions associated with the physical health care of this patient population group, followed by the mental health care, both inpatient and community care for this particular population group. So just to expand that point a little bit more, this is from the similar exercise, a different study, but where we looked at these healthcare costs by age groups, and we attributed the costs to the SMI and to the total cost. So the difference between those two being their physical healthcare costs. We can see over time the proportion of costs related to serious mental illness goes down. So for the youngest age group, 19 to 35, at least 2/3 of their total costs are related to the serious mental illness. Whereas when we get to those over 65, around 2/3 of those costs are related to the management of the physical comorbidities. So if we just look a little bit more at the relationship between the costs and healthcare resource use, and also for, as we spoke about earlier, the fact that a lot of people with SMI have these physical long-term conditions. So here in the study, we looked at people with SMI and type 2 diabetes, and we know that each of these conditions is likely to influence the severity of the other, and therefore it will result in increased resource use. So we looked at the expected lifetime costs for people with both SMI and type 2 diabetes, and we extrapolated that nationally and found that these annual costs contribute more than £250 million per year. And so we compared individuals with type 2 diabetes only, so the unexposed group, to individuals with both type 2 diabetes and SMI to look at these, the differences in costs and resource use as a result of having the SMI in addition to type 2 diabetes. And we can see, for example, here that primary care contacts are going to see your GP were much higher amongst the exposed group, those with SMI and type 2 diabetes. Inpatient stays were significantly longer. The length of stay, so the number of inpatient days, was at least 5 times greater. So much longer lengths of stay, and the total costs were more than double. The final cost I want to talk about, so we've spoken about some of the economic costs, those indirect costs, which are huge, the direct costs, and of course some of the personal costs, the premature mortality and the morbidity. But there's also another economic cost, which is really significant, and that is stigma. So people with SMI experience stigma more than, I'd say, many other mental health conditions, because they don't have the same voice as some of the more common mental disorders. And this stigma has real economic effects. It impacts on employment, income, housing, health-seeking behavior, access to treatment, and so on. And this results in a welfare loss for those individuals. It also impacts on the public's views about how we might allocate resources to the treatment of these conditions. And finally, there are some effective interventions to deal with stigma. And Graham Thornycroft has done some work around this. We still don't know much about the cost effectiveness of these interventions, but that's perhaps an area for us as economists to contribute to further. So what are some of the challenges for policymakers? Well, I think we've spoken about a number of those already in terms of addressing that mortality and the morbidity gap. But I want to just highlight a couple of other challenges for policymakers. So probably one of the biggest ones is there is this enormous treatment gap. So people with SMI often go untreated or undertreated, or they receive inadequate treatment. And there's a whole range of reasons for this. Some of those are that individuals just don't come forward for treatment. They'd rather avoid the label, avoid the stigma. They think they don't have the insight or the capacity, or don't recognize that they need care. They haven't had effective care in the past, so they don't want to come forward again. But another reason is that there are also financial barriers. So mental health care has a very high elasticity of demand. So one of the biggest reasons that people don't receive care is they can't afford it. Their health insurance doesn't pay for it, or their health insurance doesn't cover mental health conditions sufficiently or not at all. Or they simply don't have insurance. So we know that, for example, from the RAND health insurance experiment, that the elasticity of demand for mental health is much higher than for physical health. So for mental health, it's around minus 0.8, whereas for physical health, it's around minus 0.3. So when people are faced with higher prices or deductibles or co-insurance, they're much more likely to withdraw mental health care compared to physical health care. But even, as I say, when you don't have financial barriers, people still tend to want to minimize contact with services, not seek help, and avoid labels. So this is a major challenge for policymakers, because we know getting people into treatment early makes a significant difference to their outcomes. And we know that there are actually some really cost-effective treatments out there. So some of them are, I'll just name a couple of those. So for example, EIP services, or early intervention in psychosis services. So we know, again, if we intervene early for people with psychosis, we reduce that duration of untreated psychosis. They're much less likely to result in full-blown psychotic episodes, or have much better long-term outcomes. And these interventions are absolutely shown to be cost-effective through various systematic reviews, through randomized controlled trials. Cognitive behavior therapy, CBT, in first episode psychosis. We also have increasing evidence that that is cost saving. We don't yet have enough evidence that that is cost effective, but certainly seems to be cost saving. IPS is individual placement support. So this is quite an intensive support to try and get individuals with serious mental illness back into the workplace. So it's an intervention which supports both the employee and the employer. And this has been started in the US many years ago. It's been rolled out now across many countries in Europe. And we know that IPS is cost saving. It seems to be increasing evidence that it probably is cost effective as well. But I think we need more evidence on that. Self-management is intervention where individuals essentially are given skills to try and tackle and address particular aspects of their lifestyle, or their essentially how to manage their condition more effectively. And there's, again, quite strong evidence around the effectiveness of these. We're just in the middle of a randomized controlled trial to look at the cost effectiveness of this as well. So the jury's still out on that, but we hope to contribute to that soon. So there is definitely a need for more high quality evidence on cost-effective treatments. And I think one of the challenges for policymakers is sometimes the costs of these interventions fall in the health system, but the benefits accrue much more widely. And so it makes an interesting challenge for us as health economists to think about how to evaluate these interventions. But it also is a challenge, I think, for policymakers. So just to give you an example of these, if we talk about early intervention, the EIP services, or early detection in psychosis, this is a really nice piece of work. It's quite old now, done by colleagues at London School of Economics, but it shows really nicely that if you invest £1 in these particular interventions, we know that they're effective. But the return on investment on them is huge. So if you spend £1 in the health service, in the NHS, on early intervention in psychosis, the return on that will be £9.68. But the return, excuse me, outside of the health service, so in the non-public sector, is just as large, £8.02. So these spillover effects, again, because these conditions tend to affect young adults and people of working age, the economic consequences of that are significant, and those benefits might accrue significantly outside of the health service. So what are some of the care processes for people with severe mental illness, and how do they affect outcomes? So again, just to reiterate, for policymakers, we want to think about how do we get people into treatment early? How do we reduce that treatment gap? How do we reduce those barriers to access? How do we implement evidence-based, cost-effective interventions? And how do we avoid those silos when addressing challenges for people with serious mental illnesses, those spillover effects? So some of the things that we've been looking at, some of these care processes might help policymakers in terms of improving care, quality of care for people with serious mental illness. And we've been looking at how these might affect various outcomes for these individuals. So the first one I wanted to alert you to is some work we did around access and waiting times for people with serious mental illness. So these are patients in early intervention in psychosis, EIP services, and we looked at the impact of waiting times on patient outcomes for them. And this first study, we found that longer waiting times, particularly really long waiting times, so those longer than 3 months, had a very strong association with poorer outcomes. So the results from our first study there really showed us that we need to reduce those excessively long waits. We need to be really aggressive about trying to get those individuals into treatment sooner, because those have significant impacts on outcomes. Then the second study we looked at, we were trying to analyze, examine the impact of a new waiting time target that was introduced in 2015 for people with psychosis, so for EIP services, the early intervention in psychosis. And we looked at this 14-day waiting time target after the first 6 months that it was introduced. So here you can see the 2 lines that we're comparing patients treated by EIP services, the dark line, with standard community mental health teams, the dotted line. And you can see in those 2 horizontal lines, there was a sort of anticipatory effect where the policy change was announced. And we can see through a difference model, we can see that the early intervention in psychosis patients had around a 12 to 18% probability, higher chance of waiting below target. So I think that the bottom line for us is here that mental health providers seem to respond to these waiting time targets in the same way as they do for physical health providers. So we need to make sure that we are thinking about incentivizing providers to get people into treatment, to access care early, because it makes a significant difference to their outcomes. It reduces that duration of untreated psychosis, where people we know have much worse outcomes. We then had a look at some various measures of quality of care and how these relate to improving outcomes. So we looked at quality of care that is both incentivized and that is not incentivized. And we looked at 3 types of quality of care. The first one is whether a patient receives a care plan. So this is something which a provider might sit down with a patient and discuss their health and social care needs. They draw up a care plan, and it might cover things like their finances, their housing, how they want their care coordinated. If they were to have a relapse signature, what does that look like? What do they want to happen in emergencies, their sort of preferences and so on. The second quality of care we looked at indicator was physical health checks. So every year, people with serious mental illness are encouraged and supposed to have a physical health check, which covers a whole range of different areas. And then the final quality of care indicator we were interested in looking at, we looked at some others, but these are the 3 I just want to show to you today, is continuity of care. So we know that people with serious mental illness don't want to go every time to a healthcare provider and have to give their history, to talk through past trauma and so on. So continuity of care is extremely important to them. So the first 2 measures, the care plans and the annual reviews, are incentivized in the UK health system. So there are financial incentives attached for GPs to undertake those activities, but continuity is not something which is incentivized. So we wanted to look at the impact of these particular outcomes, and we looked at a range of different, we looked at these quality of care indicators on a range of different outcomes. So just to illustrate these for you, the first horizontal bars is looking at the hazard ratio for A&E attendances, so accident and emergency care. The second one is the impact on serious mental illness admissions, and the third one is looking at ambulatory care sensitive condition admissions, or what we might just call preventable or unplanned admissions. And we can see that care plans in the first one, for example, were associated with a lower hazard for A&E attendances of 26%. So care plans seem to be really good at generating better outcomes for patients, resulting in lower A&E attendances, reduced SMI admissions, and reduced unplanned admissions. Similarly, for annual physical reviews, also reducing these hazards. And for continuity of care, it also seems to have impact on reducing A&E attendances and reducing unplanned admissions. It wasn't significant for serious mental illness admissions. So the bottom line, I think, is that there are these quality of care indicators which we could incentivize, which do seem to impact. And we know that all of these activities were also had resulted in reduced costs, health system costs as well. So they seem to be worthwhile activities to incentivize. The final example I wanted to give was just around one of those incentivized activities, which is the physical health check, which is whereas again through these QOF payments, primary care physicians are encouraged to undertake a physical review for patients with SMI. So the interesting thing here is that over time, these incentives have changed slightly. So it used to be from 2006 to 2010, just a general annual review. And then since then, it was split into a number of underlying indicators. And some of those over time have been removed and then reintroduced, which gives a perfect opportunity to run a difference in difference model and see what impact this might have on people with SMI. So just looking at the uptake of these physical health checks and our DID model, we compared it to blood pressure. We compared cholesterol, BMI, and alcohol physical health checks to blood pressure, which was never removed as an incentive throughout that period. And we can see, for example, just looking at BMI, which is the red one, that the uptake of that reduced by nearly 12.5% in 2014 when the incentive was removed. And then it increased again in 2019 by 10.5% when that incentive was reintroduced. And this evidence was something which the NHS was keen to include back into their rationale for increasing the use of these incentives within the contracts that they have with that the BMA has with the British Medical Association has with GPs because they are clearly effective. So so just on that final point, then I think we've spoken about some of the incentives to access care and improve the quality of care, and these may be an important route to improving outcomes for people with SMI. And there may be some of the things which policymakers could look to, as I say, improve processes of care for people with serious mental illness. So just some final thoughts then. Why is the economic perspective on SMI important? Well, I think we've shown that it results in significant costs to society, to health services, and particularly to individuals. Some of these challenges are around access, around early intervention, providing high quality care, physical multimorbidity. And we know post-pandemic that people with serious mental illness probably suffer disproportionately from COVID. We do need more high quality evidence on cost-effective interventions, and I think as economists, we can play a role here. We need a more joined up thinking around the spillover costs and benefits and supporting policymakers in trying to understand those impacts. And then I think there's some bigger societal challenges here, which are around the unequal determinants of mental health, those socioeconomic inequalities, and some of these bigger social challenges around poverty, economic inequality, racism, violence, insecurity, and so on. So I hope that's been a quick whistle-stop tour of the economic factors around SMI, and I'm really happy to take any questions now. So I'll stop sharing my screen now.
Thank you so much, Rowena. It was amazing overview of the economics of serious mental illnesses. It's fantastic, very clear and amazing also references. So yeah, that's very, very useful. I would be happy to chair the next session. If anyone has any question, feel free to type them in the chat box or to raise your hand, and you can unmute and put your camera on if you wish. And yeah, and feel free to speak. Well, maybe while you're thinking about it, I would ask Rowena if perhaps you can unpack on the wider costs and benefits. I thought it was extremely interesting, and if you had any suggestions of what kind of instruments we could use for capturing, so identifying, measuring, and valuing the wider costs and benefits. For example, I was particularly interested in the stigma, but also, yes, on the other wider society, because standard instruments are not very adequate for that. So what would be your recommendations?
Oh, that's a great question. Very number of facets to that question, I think. So stigma is a really difficult thing to measure. There are some tools available to try and measure that, but I don't think as economists we've really had a big role in that as yet. So in some of those references you'll see that I've put there, I think the economists are starting to contribute to that debate, but there's probably more we can do. I think in our sort of standard cost of illness studies, we don't typically take account of some of these wider costs, in particular stigma, discrimination, and so on. So there's probably more that we can do in that space. And more broadly, I think there's probably a lot of work that we can do as economists around some of those labor market effects of individuals with SMI. I think we are starting to look at the impact of mental health more generally on labor market outcomes, and probably vice versa as well. There's some interesting studies which colleagues in Australia are doing around those sort of bidirectional relationships. But because those tend to be done with survey data, we tend to focus on people with depression and probably more on the less severe end of the spectrum. So it tends to be common mental disorders. And I'd say that hazard that many economists might use sort of a well-being thinking of mental health there. We're not really focusing on those individuals at the severe end and their struggles with the labour market participation. So that's why I think, you know, as economists, we could think more. There's probably more to be done around those broader costs. Yeah.
Thank you so much, Rowena. We have a question from Amin. I will read it out, unless, Amin, you would like to unmute and read it out yourself.
Sure. Hi, can you hear me?
Yes.
Yeah, I'm just wondering if there are any studies done. One of your slides showed that the income sacrificed was significant, and that given that mental health SMI patients are predominantly young, they could patients with SMI are therefore in the prime of their tax-paying life. If maybe many of the clinical interventions could be justified by just having higher tax revenues, if you could treat them and get them back to work, like not even a moral justification, but just an economic justification of treating them or ASAP. Any sort of studies done on the tax aspect of it that you can recommend?
So, so that NBER paper is a really nice study looking at those career effects of people with more severe mental illness. I think most of these studies which look at the economic impact of mental health use quite a broad brush thinking about what are the sort of production, you know, the impact on production and consumption behavior, So I would hazard a guess that there isn't really good sort of macroeconomic thinking around the impact of mental health conditions on the economy from that point of view. So I think that's again an area which we could probably as economists contribute more to. So we tend to just use quite sort of broad brush approaches to aggregate some of those costs up in terms of the loss of tax receipts, and some of those other indirect costs. And typically it's very difficult to measure things like absenteeism and presenteeism. So we do a pretty poor job, I think, in terms of trying to calculate and aggregate those costs. So yeah, there isn't a huge amount of tremendous evidence in that space, and probably more that we can do, but that NBER study might be a good place to start. They didn't specifically look at the tax component of it as again, so but they looked at some of the decrements in terms of career earnings and so on.
Thank you. Just to point out, during COVID days, there were some studies just in that narrow window that showed that the loss of tax revenues was much bigger than the bailouts that the government may have spent, direct grants or direct subsidies, and therefore we really need a healthy taxpayer base. And I'm joining in this call from Canada, and we do have tax data, but just with a medical tax credit, there's no decomposition into healthcare versus mental health versus physical health. So we can see if someone has claimed a significantly high medical tax credit to see if their earnings have since been depressed since they started claiming it. But this is an area that I'm interested in. But thank you.
No, that's a really good point. And I think, I mean, certainly in the UK, since COVID, I think we've got record numbers of people out of the labour market, and a large proportion of them on long-term sick leave. And a large proportion of a big driver of that is actually mental health conditions, as well as musculoskeletal and other factors. But certainly mental health is a big component of that. So there is a huge drive by Treasury and others to try and get people back into the labour market. So this is definitely a really hot topic, very, very much of concern to policymakers. I don't think the UK is alone in terms of trying to get people back into the labour market post-COVID.
Thank you very much, Rowena. Ewane has raised his hand. Please feel free to unmute.
Yes, hello. Thank you for this presentation. It was really wonderful. My question is whether or not incentivizing at the patient level has been researched. I know you spoke about the incentivization of the primary care physician, but trying to basically incentivize the patient population to, I guess, look at the lifestyle or to affect the lifestyle conditions at the root that you said lead to a lot of this SMI?
Yeah, that's an excellent question. So there's been a really nice study by Stefan Prieber where they looked at financial incentives for people with psychosis to try and get them to stay on their antipsychotic depot medications. So they gave them, I can't remember, I think it was about £15, which would be, I don't know, you can figure it out in dollars, to essentially stay on their antipsychotic medication because of the poor compliance and because of the nasty side effects of the medication, but because we know how important it is for people to be treated, and that was actually quite a successful study trial. It did lead to better adherence and better outcomes for those patients. That hasn't unfortunately gone anywhere. It hasn't been rolled out anywhere. So I think most of the effort nowadays seems to be focused at an individual level, at least, seems to be focused not so much on financial incentives per se or any kind of incentives, but more on support. So this whole self-management is about, for example, asking patients what is the key thing that troubles you and that you want to focus on. Is it sleep? Is it diet? Is it moving more? And sort of coaching individuals to just focus on that particular thing, so to try and make it a little bit more manageable for them to manage their condition a little bit better. Because actually, interestingly, even though we want to get patients to focus on these other areas to help themselves, a lot of people with serious mental illness will tell you that when things are tough, the only thing they want to concentrate on is their mental health. That's the only thing that they will give priority, because it's so important and so overwhelming to them. So you couldn't care less then about your diabetes or your hypertension. What you want to focus on is just getting your mental health better. But nevertheless, I think so these sort of management techniques and so on are probably more, and the support that we can offer them at an individual level is probably more where the focus is at the moment, even though, as I say, there have been some interesting evidence around financial incentives as well. But that's a great question.
May I just step in, Julia? Sorry, just
yes, of course, Francesca.
I have a thought which is somehow related to what we're just describing now. So what related to the mobility gap that you've described and the socioeconomic factors that play a role in it, what do you think of the role of community network, social and community network, in kind of easing the situation? Are you aware of any work on this? And if yes, how did they measure the support, the network that the individuals can rely on in case of need?
Yeah, that's a great question. So there are these network analysis studies and stuff and so on, which, as a methodology, which I suppose one could employ in this kind of scenario. But we know that social isolation is a big factor for people with serious mental illness. So they tend to be far more isolated and don't have these kind of networks. I'm not actually aware of any interventions which have focused on sort of trying to reproduce these networks, other than through for example, some of the trials and so on that we've been involved in. There might be group interventions, but those are kind of time limited. They're not really setting the individual up for a community which they can lean on post an RCT. So I'm not aware of sort of longer term efforts to try and teach people or how to find themselves a community or engage in a community or anything like that. That would be an interesting area of exploration. It's a good question.
I guess it's very difficult to understand where the causality, in which direction it goes, right? Do I have 10 friends versus one because of who I am, or am I? So I'd like to talk to you more about this because of an ongoing project that we have, and so maybe not now, maybe another time.
Absolutely, that'd be great.
I think that we reached the hour. So I would like to thank so much, Rowena, for your knowledge and for sharing it with all of us. And thank you everyone for joining us. Dai, for your support. And so this is we will do this. We're trying to have this 3 times a year, but it's not always easy. So if you would like to present anything on mental health economics, please reach us as the SIG conveners, me and Francesca and the others, and we would love to hear from you, so we can strengthen our communities. And Rowena, thank you so much also for the insights on future research needed. Lots of food for thoughts, more to discuss in another time.
You're welcome. Thank you very much indeed.
Thank you so much, Rowena.
Bye.
And thank you, Dai. So you will put it online, right, Dai? Yeah, beautiful. Thank you so much.